Thank you everyone for joining in to this webinar. My name is Jaafer Golzar. I'm an interventional cardiologist out of Chicago, as well as the Chief Medical Officer for Avinger. And today we're going to continue our webinar series that we started a couple of months ago. As you guys know, during these difficult times, there's been significant lack of education. There's no conferences. And so at Avinger, we're really committed to continuing education. And so we wanted to do this by having a webinar series of really important and pertinent topics. And so we've had a couple of webinars already. Dr. Davis, Dr. Schwartzberg presented, and today I'm going to be presenting a webinar on Seeing is Believing, OCT Image Interpretation in Peripheral Arterial Disease. And I thought, this was important to kind of go through all of the image interpretation, because I think that's one of the biggest limitations and one of the biggest challenges that people have with OCT is just not knowing what they're looking at and not knowing exactly what they're actually interpreting. And so I thought just sort of going through the nuts and bolts of what we're looking at, how it works, and the practical implications of that. It's an honor to have two of my great friends and world leaders in OCT and peripheral arterial disease, but also in OCT, Janzer and Sean Janzer and Ed Pavillard on with me as panelists. And these guys have done a ton of OCT. They know this technology really well, not just the Pantheris and Ocelot technologies, but just OCT and what they're looking at. And so I'm going to go through a few of these slides and kind of go through the basics, and then we're going to have Janzer as well as Sean go through some of, Janzer as well as Pavillard go through some of these as well. So we'll start with some OCT imaging, so go through image interpretation, go through our conclusions, and then a panel discussion. So as I mentioned, I have Dr. Pavillard Dr. Pavillard with us. Did his DO in 1999 from Philly College of Osteopathic Medicine, and he's a vascular surgeon. We've had several vascular surgeons actually that work with us and do a great job, and Pav is definitely one of those that does a ton of endovascular work and is really a master in the OCT technology. He did his vascular fellowship at Philly College of Osteopathic Medicine, and then at Phoenix Hospital in Pottstown. Where's Pottstown? Pav?
Northwest of Philadelphia, about 25 miles.
Ooh, all right. And then my good friend Sean Janzer, again, interventional cardiologist, but a true expert in peripheral vascular disease as well as OCT technologies. He did his internal medicine residency at Heinemann in 1989, then his fellowship at Drexel in interventional cardiology at Einstein Medical in Philly, where he remains in the Philly area and is in practice there. So it's really an honor to have both of you with me today. So just kind of going through a couple of basic points. OCT, what is OCT? So OCT is similar to intravascular ultrasound. However, instead of intravascular ultrasound using sound waves, OCT uses reflected light. It uses a near infrared light, about what we use is 1310 nanometers. It scans at about 20,000 scans per second and from the laser itself, and that's what gives us these beautiful images, high resolution images of approximately 10 microns in resolution imaging. And so what you see here, we're going to be going through a lot of this during this talk, but it was initially discovered and published it was discovered before 1991, but initial publication was in 1991. And early on, OCT was really confined to the ophthalmology world, and it's still used very frequently in ophthalmology. The advantages for imaging, be it ultrasound, be it OCT, be it CT or MRI, is as the resolution increases, meaning that number, that micron how close you can get to the visualization, the penetration depth is going to decrease. So as you can see here, really next to a microscope, the OCT has the highest resolution at between 2 to 10 microns, but the penetration depth is very low. Next is going to be your ultrasound, but the resolution is lower, but penetration depth goes higher, and so forth and so on. And really, a lot of people are familiar with intravascular ultrasound and kind of know it, because especially as a cardiologist or vascular surgeon or interventional radiologist. So, but a lot of people are just not as familiar with OCT. Cardiologists use it frequently in the coronary wall, but really outside of that, not really. So we thought, you know what, it's probably a good idea to see if we could do a head-to-head comparison. So we took on this scan study, and yours truly, Dr. Pav, is one of the co-authors and primary author for this study. And basically what we did is we matched up OCT versus a scan versus intravascular ultrasound in patients and compared those structures. And so we had 240 images from 12 subjects, and these were blinded physicians that examined these. And we looked at different things: layered structures, non-layered structures, calcification, stent struts, and artifact. And what was the finding? Well, they found when it comes to layered structures, the resolution or the image interpretation is really no different between intravascular ultrasound or OCT, but it's just as good. So they're equivocal. However, in non-layered structures, in calcification and stent structures, the OCT images are much better to interpret than intravascular ultrasound. And artifacts are similar between OCT and IVUS. So it's sort of, you know, it's kind of hard to put these slides next to each other, because you're like, it's kind of a no-brainer when you look at IVUS imaging versus OCT imaging. The resolution, the amount of clarity that you get in the images is sort of a no-brainer. But you know, some people are just used to intravascular ultrasound, and they know what they're looking at. And so OCT is sort of something new, and it's hard sometimes to learn something new. And so that's why we thought it'd be important to give this talk, just to help understand what you're actually looking at. So when going through this talk, I'm going to talk about some normal vessel architecture, the different types of plaque, dissection, calcium, and what atherectomy cuts look like with intravascular ultrasound. So when we talk about OCT, we have such fine detail that usually we refer to either layered structures or non-layered structures, because our detail and resolution is so great that we can really differentiate these layers so nicely. So we kind of separate it out into those two groups: layered structures and non-layered structures. So what are the layered structures? This is what we see physiologically or pathologically in a normal human artery, and we really can't see this with intravascular ultrasound. So as you guys know from medical school and the basics of arterial anatomy, you have the intima, is that thin layer of cells which separate from the lumen to the beginning of the artery, and you can actually see that here. You have the external elastic lamina, and this is one of the things that we've always taught about, is looking for the line, and that line is basically the differentiation between the media, and then past the line is no man's land, and that's the adventitia, and that's where you don't want to be. I mean, you really don't want to cut the media, but it's not the end of the world. If you cut the adventitia, bad things happen: restenosis, perforation, things like that. So this is what you can see on OCT, that we have such precise imaging by OCT, because the resolution is so high that you can see each of those layers: the intima, the media, the external elastic lamina, and then far field, the adventitia. So what does this look like under OCT? Well, the necrotic core are signal poor regions within the atherosclerotic plaque, but they're much larger than what you would see from just the basic lipid pools. You wouldn't see much of a border. They're just these large lakes of just blank space behind the fibrous cap, because the fibrous cap is going to have that bright signal, and then you're going to see in the background just nothingness. And the fibrous cap is sort of that what's allowing that necrotic core from rupturing into the artery and causing a thrombus. Is sort of that fibrous cap that is protecting that necrotic core. But that's where the acute myocardial infarctions originate from. And you can do atherectomy here. You can shave these out. You can shave out these necrotic cores as well. And we can see this under the microscope, what it looks like. We see the fibrous cap, and we see necrotic cores. And I welcome you, if you guys are using Pantheris, feel free to talk to your rep and send some of these in, because you can get some really cool images such as this from your actually removed atherosclerotic plaque. Thrombus. So thrombus is an area that looks like mass that's attached to some luminal surface. Sometimes it's floating in the wind. And this is sort of important because it may change how you treat these patients. There was one instance where I didn't really appreciate that there was going to be so much thrombus when I crossed with an ocelot, and then I actually did not perform directional atherectomy because I was afraid of distal embolization. And so I gave thrombolytics with power pulse, and then jetted it, and then treated that patient later. So these types of things can help change your practice and how you treat these patients, and do have clinical significance. Here's another example, a couple of examples of what thrombus looks like. A little finger that's floating in the wind there on the left-hand side and in the middle. And then obviously removing these and performing atherectomy. You can shave this out. So again, just kind of going back, again, it's kind of a no-brainer when you look at these images. A thrombus with IVUS on the left, thrombus, same image on the right, with OCT imaging. So much clearer, much higher resolution, as promised, what we see with OCT and compared to intravascular ultrasound. This is what a dissection looks like, and we see this pretty frequently. And usually we see this because a wire dissection is usually the most common thing. So this is from a cadaver artery. However, this is clinical images from wire dissections, from balloon angioplasty. Here's a really nice case from a few months ago. So here on the left panel, you see we're actually in the medial space, and this is a below the knee Pantheris case. And so one of the cool things about this and working below the knee with the Pantheris SV is, we've always been a little intimidated with working below the knee because we really don't know where we're cutting. Well, here's an example of a wire dissection. So here at around between 9 o'clock and 12 o'clock, you see the actual artery that's collapsed. You see the black lake here, which is supposed to be the lumen, but this is the wire dissection. Now the Pantheris device was in the wire dissection, but what you can do is you can cut away from that. So you can cut away from the adventitia, the media, and directly cut the plaque. And here's a live example of what we did there. And so we turned around. This is one of the cases we did early on in Germany before we launched the device. So here we're targeting directly that area of plaque after the wire dissection. And this is what it looks histologically. You see a lot of fibrotic tissue and neointimal hyperplasia as these stents restenose. And far field, you can see these actually pretty easily as well. So these stand out pretty easily. It's kind of a no-brainer using it there. One of the most challenging subsets that we encounter treating PAD is calcium. And I believe that calcium, this is one of the most exciting things for me because it's really been enlightening since we've had the Pantheris SV, because we really have never known what calcium distribution looked like below the knee. We sort of just assumed that it was intraluminal calcium. That's what we all assume. And then we use different types of treatment algorithms, orbital atherectomy, rotational atherectomy, because we just kind of feel that calcium's right in the middle and we drill that out. But it's been really enlightening since we've had Pantheris SV to really understand where is the calcium distribution below the knee. And we're going to kind of go through there. So calcium can be in 3 different places. Here you see by the arrows, this is intraplaque calcium. So there's a fibrotic cap to it. There's calcium behind that. And then you can see in the middle as well, the calcium behind the fibrotic cap. And then there's the images, the pathologic images on the right. Now, that's very different than when you see luminal calcium. So the middle image is luminal calcium. So you see those mountains and those peaks and shards of glass almost in the lumen of the vessel. That's luminal calcium. That's where we can shave that with directional atherectomy. You can drill that with orbital atherectomy or rotational atherectomy. However, you can't reach what the calcium on the left-hand panel with orbital atherectomy, right? Because it's further deep inside the vessel wall. And so this is where directional atherectomy really shines, because you can direct your cutter and shave directly, direct your cutter and shave directly where you want to, which is cutting out that calcium and removing the calcium from the vessel. And again, here's another example of a beautiful calcium nodule, a large calcium nodule within a vessel, and right next to it, embedded within a plaque. Now, here, these are some images for Pantheris SV below the knee, and this is what's been so enlightening for us, is how, first of all, how much calcium there is below the knee, but also where is the calcium distribution. So what we see more and more is the calcium is distributed within the plaque, as you can see on the left panel, as well as here you see within the plaque as well, but then you see this within the media, right? Because this is our EEL, then we see some media, and now look at what we have here. This is what we have seen more than anything, and this is what's been so incredible and so enlightening, is this deep wall calcium, the medial calcium, also known as Mockingbird medial sclerosis. And so this you really can't reach with anything but directional atherectomy. However, you really don't want to cut that out. Why is that? Because that is now the barrier to the adventitia. Because when you have medial calcium, that has replaced the media. There's no more media. It's destroyed the media. Past that is adventitia. So we leave that alone. We cut up to the medium. So we've always taught EEL, EEL. Below the knee, there is no EEL. There's plaque, there's Mockingbird calcium, and then there's adventitia. And so that's what's been so enlightening. And we've never known that before, because we've been dealing with these images on the right. As you know, calcium bounces sound. And so you don't really see a far field. You can't see what's going on in the EEL. You can't see Mockingbird calcium. And that's why it's been so incredible to have these images. And we're still learning case by case, and we're still trying to understand the distribution of calcium and how much and how to treat these patients, and how much, which ones should get adjunctive therapy, which should not. So it's opened a whole new world for us with Pantheris SV, and really understanding calcium distribution below the knee. So just to kind of bringing it all together, this is what we see when we're using directional atherectomy. So a beautiful image of, this is a 7 French Pantheris device. You can't perform targeted therapy and stop exactly where you need to stop at healthy tissue, and cut only plaque. Can't really do that with anything else. You can't really target, because there's nothing else out there that will allow you to visualize exactly what you're doing. Because as you all know, that fluoroscopic imaging doesn't cut it for really 3-dimensional imaging, or circumferential imagings that you can see here. So here's another example of that. You see the EEL media, and again, props to Gabrielle for these beautiful videos and labels. The EEL media, thick intima, and really turning that catheter around, focusing directly on non-layered structures, right? No layers. Now you suddenly see the layered structures, and then boom, that's where you stop, and that's where you stop your cutting, and then turn around and keep going. And that's sort of the advantages that we see, the clinical advantages, and just kind of bringing everything together. And there was a trough right there. You see, as the balloon is deflated, you can see the trough, and then you see the media, you see far field adventitia, and then you see exactly where we can stop. And there was some calcium there. So this is all real time. This is happening, real time as we're moving the catheter. So it's really a powerful tool. So I want to kind of go back to what we talked about in the beginning is sort of normal architecture, but I wanted to bring it at the end of it because this is going to wrap it all up. So we kind of talked about normal architecture. We talked about adventitia and no man's land. So this is what no man's land looks like. This is the adventitia, the honeycomb appearance. So you can see it here, this honeycomb appearance. That's where you don't want to be. You can get there, even with OCT technologies. You can inadvertently get there, or you could have a wire that has gotten into the adventitia, and then you put your directional atherectomy catheter device, and you're like, uh-oh, I was actually in the adventitia with my wire. Had no idea. But then the advantage is you can direct away from that and cut the plaque and remove what you need to without cutting into adventitia, because that's what leads to restenosis, and that's what leads to perforation. So kind of wrapping it all up, what does it all mean clinically? Why do we care about all of this stuff? Well, because adventitial disruption leads to restenosis. We know that. We know that from a older study that used a non-imaging directional atherectomy catheter, and they found that they did patients, and then they followed these patients at 1 year and looked at restenosis. They sent these to the lab to evaluate the plaque, and they found that 53% of the time, blinded atherectomy, directional atherectomy, 53% of the time that you have adventitia. So that in itself is enlightening to know that 53% of the time you're going to have adventitia if you do blinded directional atherectomy. Now, that being said, what they found was that if you have any adventitia, any adventitial disruption of the artery, you have a 97% restenosis rate at 1 year. That is truly incredible. And that has been replicated. And we know that if you disrupt the normal vessel architecture, that you're going to have poor outcomes. It makes sense, because that's what incites restenosis. Whether it be with barotrauma with the balloon, whether it be barotrauma with the oversized stent without drugs, that's what incites restenosis. And so here's an example of cutting media into right up to your adventitia. You can stop at the adventitia when you have imaging. Now, here's another example of what adventitia looks like, the honeycomb appearance. So at 12 o'clock, you have normal tissue. That's where you should be. And you're actually in the adventitia. So again, knowledge and power. You know what you're doing. You know where you are. You know the next steps. How should I treat this patient? And histologically, it looks the same way, almost identical to what it looks like with OCT, which is that honeycomb appearance. Another example of adventitial imaging with OCT, and I've kind of showed 2 or 3 of these because this is really important. This is so important for you guys to know if you're using OCT technology, because this is what you don't want to see. You don't want to be an adventitia. So this is sort of that warning, blinking red light, say, get out of here, you know, treat away from adventitia. So this is why I kind of had 2 or 3 of these slides up. So what is the ideal atherectomy cut? Ideal atherectomy cut excise everything up to the media when the media can be identified. When you can't identify the media, then about 0.3 to 0.5 millimeters away from the EEL. Why? That's sort of your safe zone. Because as we mentioned with the medial calcinosis, with the Mockenberg calcium, we don't know where's the EEL. We don't know where's the media because it's been destroyed. So stay about 0.3 millimeters away from the EEL. And this way you can keep the normal arterial wall intact as far as we know, because this is a brand new world for us right now. We've never encountered this, so we're still learning. And we have new studies that are going on to look at restenosis with Pantheris SV below the knee, that we'll be able to understand exactly which should be cutting, how deep should we go, do we have the same issues that we do in the SFA? And so it's a really exciting world right now for us for below the knee disease and OCT technologies. And so again, in the VISION trial, we also showed that luminal gain is key. The more the luminal gain, the better you are with primary patency. With the vision trial, we also, again, 1% adventition. Remember, this was the first study we did. I was involved with this. We went out to Germany and were trained in how to use this technology. And, you know, several of us were same thing, where we went out and we were sort of, you know, just starting to learn how to do this. So just in a new technology, 1% adventitial cuts versus non-imaging modality, 53% cuts, you know, adventitial cuts. So big difference. And then in terms of, again, wrapping it up, clinical utility with primary patency, I'm going to pull a little bit from definitive AR, which showed that if you improve a definitive AR, for those of you who don't know, they use directional atherectomy with DCB versus directional atherectomy with balloon angioplasty. And at the end of the day, they found no difference. There's no difference. And we're like, wait, that didn't make sense, because we all thought that vessel prep was so important. Well, what we found out is it was a traditional directional atherectomy catheter. When you do subgroup analysis, if you have less than 30% residual stenosis after atherectomy, and then you perform DCB, then you have better clinical outcomes. You have improved primary patency at that point. But we don't always get less than 30% residual, because we're walking on that fine line where we're doing traditional directional atherectomy of, have I removed enough, or am I removing too much that I'm going to cause adventitial injury and perforation? But that's the promise and the hope for image-guided therapy, is you can remove maximum amount of plaque and leave the normal vessel behind. So these are my conclusions. I've done a lot of talking, and I want to kind of turn it over to my great friends here, Sean Janzer, who are much more you know, astute and intellectual about OCT technologies, because they've been doing this for years and have done a ton of work. And so I definitely want to turn it over to these guys, and we're open for questions now. I should have mentioned this before. So you have a Q&A part on top of your screen or on the bottom of your screen. You can click on that, you can chat, you can type in your questions as we're going through the discussion part. Any questions, it doesn't have to be about OCT technology. It can be about anything peripheral vascular you want to talk about. Just throw it on there, because these guys are truly experts, not only in OCT, but really in vascular disease in general. And we'd love to get your comments or questions and kind of walk through some questions. But I'm going to start off and kind of talk about this a little bit, and talk about, you know, OCT technology. And really kind of what I hounded on was this calcium below the knee. And Sean, I know you've been using, Sean, you and Pav, both of you guys have been using 7 French device below the knee before we had Pantheris SV. I actually did that my first case after I found out, Sean, that you were doing that. I was like, damn, why didn't you think of that first? So I actually did that after I found out you were doing that. But tell me, what is it? I mean, what have you found the difference?
So I think it has been healthy to go down there in the 7 French system, especially the tibioperoneal trunk. It's a little harder and a little more challenging in the anterior tibial, just because of the turn. So it really depends on what kind of turn you have. Mm-hmm. But you're not going to have a big problem if the sizing is right. So, and I'd like to hear what Pav says, but I think he's offline right now.
Yeah, that's what I was wondering. So, he was online. Yeah. I don't see him anymore.
Yeah.
While he's reconnecting, quick question for you. You know, I usually use distal protection for SFA pop disease. What about for BTK disease when using SV? Do you use distal protection? First of all, do you use it for SFA pop, and then do you use it for below the knee?
Yeah, invariably, if I have room for it above the knee, then I'm using it, and I think that's pretty much what a lot of us do. I think below the knee is a little bit more problematic, but because you know, you just sometimes don't have enough room. And then the other thing is, it's not as soft and friable, right? You talked about the calcium and how that is down there. So if I'm working down there, it's usually patients that are pretty calcified. So yeah, you can send calcium down there, but you got a 6 French. you see what you're doing, and I don't do it as much down there, but I will if I'm worried.
What about spasm?
Yeah, it's funny with the spasm is sometimes you have to walk away and it's spasm and you got a good result. And I think we don't talk about that very much, but I'll take them out to the cath lab recovery area and now they got a bounding pulse down there. You just can't wait a half hour for it to go away. So it's kind of a great question because we don't talk about it very much.
Yeah, I think that's one of the things, I teach my fellows all the time. I think one of the biggest growth factors when you're out of training and just learning is when to walk away. When is it just going to get better? When you just leave things alone, and I think definitely that's one of them. And now Pav is he's having some computer issues, so he's going to try to connect back. So it's a good opportunity for us to talk. Now, do you with the device you can use vessel measurement? Do you ever do that, or do you just kind of when you're doing it you just guesstimate?
Yeah, it's nice to know you have it. I don't walk away from the table and measure it. Sometimes I have our super reps, Bill and Mike. They'll make the measurements. Sometimes my ADD gets ahead of me, and I've IVUSed it before, so I know what I'm sizing. So if I'm stenting or doing DCB, I really do like to have an idea because I think I've been undersizing for about 20 years until we started doing imaging. But I think imaging not only teaches you for each patient, but it also teaches you for the patients that you're going to treat without imaging later because you're estimating sizes better.
Yeah. So, I don't really size as well, but I know there's a lot of people that love to size. And like, as you mentioned, a lot of them, put an IVUS down, but obviously here you could just sort of save a catheter if you just put the OCT catheter down and then just size it based on that. I just kind of guesstimate based on just my experience and what I think the size should be. But it's now that you mentioned Mike Dembski, just props to him as well for being your rep and helping you and Pav out, kind of getting this together. I appreciate him coordinating everything. He is one of the super reps. So
we've all been sort of doing this together. You and I in Germany a long time ago.
Yeah,
so,
that's right.
It's fun.
Now, what about adjunctive therapy? So let's say you do directional atherectomy. You have less than 10% stenosis below the knee, less than 20% stenosis, because that's what I've seen is, you can maximize your cutting. Do you follow with the balloon? There you are, Pav. How you doing, buddy? Computer issues, tech issues?
Yeah.
It's all good. We'll catch up in just a second. Yeah. So we're just going into adjunctive therapy. So I was just asking Sean. So we go through, we do directional atherectomy. You have, let's say, 10-20% residual stenosis. We're talking BTK first. So you have 10-20% residual. Do you do a regular balloon? Do you put in a tack? Do you do coronary DES, or do you just walk away?
Most times I'd say I'd probably walk away if there's only 10 to 20% residual. I don't routinely stent below the knee with the coronaries. I don't have as much access to them, number one, but depending on the size of the vessel too, because some of the vessels are larger than advertised. So I've used a drug-eluting balloon down there or plain balloon, but I'd say that with 10 to 20% residual, I'd probably let it be.
What about SFA?
SFA, are we still talking about the 10 to 20% residual?
Yeah, let's say you have good results. Let's say less than 30% residual. What do you do next?
It depends on the morphology of the plaque to some degree as well. If there is a lot of calcium left over, I think those are cases where I do tend to use more DEB. If it's more of the fibrous plaque, I would probably leave it alone.
What about you, Sean?
Yeah, I think the clinical issue there too is if it's restenosis, clearly I'll think DCB. I think one of the points of this whole technology and the idea of seeing it is that you can get away without stenting and then leave some choices later, especially at branch points. So even as a cardiologist, I try hard unless it's really ripped up down there to not stent. But you still want the thought that you might get laminar flow, especially for these critical limb ischemia. patients. So if it looks real ragged, then I'll stent them, just basically for healing, you know, in their early phases.
And then what type of stent would you use? What do you like to use?
I use the drug-eluting coronary stents below the knee if I can. But sometimes, you know, the tibioperoneal trunk can be pretty large. So
Yeah.
it can be a 5.0. You can get a whole bunch of different kind of stents in there, like Superas and, you know, Viabonds, and yeah, it's kind of amazing when you start imaging how big these arteries get.
Yeah.
Especially after you cut them.
What about for SFA? What's kind of your go-to stent if you need to?
Yeah, I use a lot of Superas, but you got the whole issue of how you land it, right? So you can go from below or from above so where do you want to nail? Like what end do you want to nail? So I'll use those on occasion, and you know, if there's any concern, I have a low threshold for using the covered stents. I don't know how you guys feel about it.
Yeah.
But I don't mind the Viabonds in short segments, not across joints. I think they can be pretty helpful.
So
They are a little.
Yeah, there are a couple of. I want to ask both you and Pat this question: is where do you feel SV? When are you like, yeah, probably not going to use this device here? You know, what are the limitations? When do you say it might not be the best case for Pantheris SV for below the knee?
For me, it's the turns. So if it's a nasty AT, that's where a nasty calcified AT, I'm not going to force it around if I'm worried about tearing it. That's not a great place to tear, and our vascular surgeon can talk about the problems when we tear stuff. So, but that's, thank God we have covered stents. So that's the area I look at. Otherwise, I'm pretty comfortable doing it. And if it's super calcified, I'll probably back off on it as well.
What about you, Pat?
Yeah, I would say the same thing. I mean, not every AT is the same. There's, you know, a lot of the proximal ones that have up to 90-degree angulation. Those are, I think, not the best place to use them. And then as far as, you know, distal disease, you know, I've taken them all the way down to about the ankle mortise, but they've got to have a pretty healthy pedal runoff in order to do that. And again, not a ton of calcium down there too.
Yeah, all really good points. You know, I don't mind the AT too much. What I usually do is I'll put in a stiff wire, like a Grand Slam or anything, kind of straighten things out a little bit. And then, you know, obviously we have the imaging. So that's the sort of the advantage of it, is to kind of allows you to know exactly where to cut away from. And so, you know, I remember when I would use non-directional atherectomy, there's sort of all these rules you have to follow, you know, cut away from the angle first and then cut into the angle. Here, I feel like, you know what, I see exactly what I'm doing, so I can cut whatever where I want to. So I haven't had too much issues with that. I think the biggest challenge that I've had is, you know, as we've seen, a lot of this calcium that we're seeing is intraplaque, Mockingbird, deep wall calcium. But sometimes you will run into luminal calcium, and you'll have these shards of glass that are just sticking out, you know. And so I'll you know, if I see like a long AT or PT, peroneal, whatever, CTO. And it's sort of, I have a hard time even advancing my Trailblazer or Quick Cross. I'm like, I'm gonna have a hard time with this. So then I'll usually pre-dilate with the undersized balloon, like a 2.0 balloon, 2.0 long balloon, low pressure, and then try to bring it back down. Sometimes it works, sometimes it doesn't. You know, if you have that luminal calcium and you have those shards of glass just sticking out, it's just not gonna go, you know? So that's probably the most challenge that I've had.
And my experience with those two is that you basically get one pass with a catheter with it, because you create a groove, and then I think the the catheter tends to just fall back into the same groove. So I see that you'll get plaque, and you'll be able to be effective the first time through, but the second and third passes, you're not. You know, I fall into the same channel for the most part.
And then the other thing is that, you know, for that distal disease that you were talking about, that's a really, really good point, because that can be tricky, and it kind of freaks people out, because, you know, it's a bigger nose cone. It's just like you're just putting a bigger nose cone down there, down into the dorsalis pedis, and it's already a little tricky, as you guys know, like doing below the ankle work is just so spasmodic. Usually I'll give 30 of papaverin longer acting nitrate, and I'll usually just pre-treat with nitro. So I'll just give like 500 mics of nitro before I even go in with the device if I know if I'm going to go all the way down to the ankle. But those are all really good points because, you know, early on when I did first couple of cases, you're right, you have it. It was I think it was like a PT, I had my nose cone all the way down in the lateral plantar, then you pull back and you see sort of no flow. Boom, throw some nitro in there, it opens it back up. Sean, what about you? What are your challenges in terms of using with calcium?
Oh, calcium. I agree with you about the AT. The other issue is if it's really heavily calcified, you're going over the horn and you have a kind of funny axis. It sometimes it's a little hard to push it through. So I think that's. But you know, I don't take it all the way down into the foot very much. It's just my style on how I do things. But it's certainly, if I can see something, I'll do it. I mean, I think it has to be big enough that, you know, 2.5 and I'd be fine with it, even into the dorsalis pedis if it's okay. And
what about antegrade? Do you guys like antegrade crossover? Let's say it's truly below the knee disease and you know it getting into it. You guys like antegrade crossover still? What do y'all do?
Yeah, I would prefer antegrade, but there again, you have anatomic limitations for some people.
Yeah. What about you, Sean?
Yeah, the same thing. It's also a good thing for the fellows to see is, you know, is doing the antegrade, and I'll often oddly stick the SFA directly, so I don't have to stick through a ton of panis, and then I just close it. You know, the SFA early in it's pretty easy to close, and it's really I think often a better place to stick.
Yeah, I'm glad you brought that up because I've actually started doing that because of just limitations. You're like, I have no choice, and you do it if you're, you know, confident with your closer devices now. I mean, 99% of the time, if you know what you're doing and the limitations and the physics behind the closure devices and how they work, the mechanics, you can, you know, usually they'll work and you can close it pretty reliably.
It gets down. It gets down to the issue. You're going through, you know, 3 inches of panis versus, you know, an inch. I think there's a huge difference in the hematoma rate, especially if you have to hold it, if it's a failed closure. So it's just easier to do the SFA.
Yeah. So we had a question that came up. Do you see a lot of deep wall calcium in the SFA? And so kind of, you know, what I talked about for below the knee is, you know, we had a lot of the Mockingbird calcium, deep wall calcium. What do you think? What do you think, Janzer? Sean?
Yeah, I think that if I see in the SFA, I think they run together. I think if I see deep wall, I'm going to see a lot of intraluminal. At least that's my perspective on it. Although, you know, you can't see it that well when you do IVUS, and so I do a lot of IVUS just because of the imaging issues with OCT initially. You know, if there's a lot of calcium, I'm not going to try to drag something down there. But I think they travel together up top. And we've all seen those little micro channels that are all stone. You know, there's calcium everywhere. And Ed can talk about it since he gets to cut into them. They're just video games, you know, video pictures for me. But it is pretty scary, a lot of calcium. And that's the bane of all of our existence in the coronary and the peripheral space.
What do you think, Pav? What do you think?
It is, and I think it's a little bit more common in the, you know, long-term dialysis patients in particular. You know, they're going to be head to toe calcium a lot of the time. And they're the most challenging people.
Well, thank you guys. It's been an hour. It's been a great time.
Yeah, thank you.
Thanks with you guys virtually, and I want to really thank the audience as well for joining us today, and everybody that's put all their hard work into this. All the attendees that have taken some time away to join us, and feel free to give me a text or send me a message. We'll have a follow-up email to you guys, and if there's any follow-up questions, please don't hesitate to let us know. This will also be available online later on. We'll have this recorded. This has been recorded, but it'll be available later on if you want to share it with your friends or watch it later. Thank you very much, and we look forward to our next webinar in a couple of weeks. Thanks, guys. Have a good night. Stay safe. Bye.